I'm Maureen Abbott, and I'm so glad you could join us for today's fireside chat, Eating Disorders and Technology, Challenges and Opportunities Across the Spectrum of Care. I'm Director of Innovation at the Mental Health Commission of Canada. And at the Mental Health Commission of Canada, we have a unique mandate from the Government of Canada to support federal, provincial, and territorial governments, as well as organizations, to incorporate best evidence into public policy through research and knowledge translation. And we collaborate with national partners in all of our work and often international as well. And my team at the Mental Health Commission focuses specifically on policy and research, incorporating lived and living experience into our work through our lived experience councils, and also e-mental health, of course. And on the e-mental health side, we have an MHCC app assessment framework that we developed. And we also have an e-mental health strategy for Canada that we launched at the EMIC Congress last September. And we're also developing artificial intelligence guidance for mental health and substance use health with the Canadian Centre for Substance Use and Addiction. And I'm also honored to chair our e-mental health collaborative in Canada, which is a group of experts in e-mental health that provides us direction and strategic advice. And one of the members of the collaborative, Shailene Jones, is from Eating Disorders Nova Scotia and also founded Body Peace Canada, which is an online platform that provides eating disorder support without requiring a diagnosis. And I think Shailene is also joining the call today. And we know that eating disorders are complex and deeply personal experiences that affect people of all ages, identities, and backgrounds. And their effects ripple out beyond individuals to families and also communities. And we know that digital health tools are really changing mental health care, giving people new ways to heal alongside traditional therapy. But with all that potential, there are some big challenges too, like making sure that these tools are actually safe, effective, and available to everyone who needs them. So today's session is hosted in partnership with the Consortium for Research in Eating Disorders, which is an international not-for-profit organization founded in Australia. And it's our privilege to be joined by an outstanding panel of experts from around the world, each bringing their own unique perspective to this important issues. And you'll hear from our speakers very soon, but first I wanted to have a quick chat on a few items that I wanted to mention. So first, feel free to share your current location or area of interest. And to do so, you can click on the three dots next to your name tag and then choose Edit and add your country or your area. And this allows you to connect with others who share similar interests. And if you have any questions for the panelists during the webinar, please feel free to post them in the Q&A box. And during the Q&A session, I will do my best to include as many of them as possible in our discussion. And lastly, today's webinar is being recorded and the EMIC team will soon share the recording in the Knowledge Bank. So now it gives me great pleasure to introduce our first speaker, Rachel Burns. Rachel, would you like to join us?
Hello,
Thanks,
get my screen up for you all.
And I'll introduce Rachel as well as she brings her screen up. But Rachel is a 22-year-old lived experience mental health advocate living on Whadjuk Noongar land in Western Australia. And she is also fiercely passionate about humanizing mental health treatment and recognizing intersectionality, especially for neurodivergent, queer, and disabled folk. Rachel sits on several state and national advisory boards, volunteers tirelessly, and also works in and alongside many organizations using her lived experience expertise in pursuit of a kinder, more accepting, and humane world. And she's now going to share her personal journey with an eating disorder, the gaps she faced when seeking support, and the insights she's gained from her work as a lived experience advocate involved in co-designing digital mental health tools. Rachel, we're so glad you're here. Please go ahead.
Sorry, it's just not letting me get my screen up properly. There we go.
No problem. You're almost there, Rachel.
Cool. Can you see my screen? Oh, there we go.
Can you
All
get
right,
see
got
my
it.
screen? There, perfect.
Perfect. So,
Thanks,
hi,
Rachel.
I'm Rachel. I am excited to be sharing a lived and living experience perspective on digital tools for eating disorders as someone who's neurodivergent, who's in active recovery, and who's also experiencing many co-occurring mental health challenges. I want to just disclaim as well that while I try my best to convey beyond my own perspective, I am inherently tainted by my own experiences and I can't speak for everyone. So, eating disorder treatment as it currently exists is designed specifically for neurotypical people, despite the overwhelming evidence about the linkages between eating disorders and neurodiversity. Those experiencing eating disorders who are neurodivergent are more likely to be seen as treatment resistant or having poorer treatment outcomes. Eating disorder treatments are still specifically revolving around body image and appearance. And whilst this certainly is a factor, and for many people might be the primary factor, it's certainly not the only factor, and definitely not for neurodivergent folk. One of the greatest similarities between neurodivergence and eating disorders is a tendency to think in black and white or to think in extremes. The problem is that rigid thinking cannot be combated effectively, in my opinion, with a different form of rigid thinking. Still, treatments, tools, and resources themselves still operate so rigidly. I think that they need to have variance and flexibility embedded within them. As a mental health and disability advocate, something that I think is key to understand is the models of disability. We live in a fundamentally biomedical world. As someone receiving treatment, this is always felt patronizing and punitive. Any successful tool, in my experience, leans more into the social and human rights-based approaches to mental health and to well-being. That means steering away from the idea that a person's behaviors are defective and that they need to change, and more into supporting them to act in ways that align with their values. I think this is why DBT is showing more efficacy, especially the more radical forms of acceptance. That said, at different times, different approaches are certainly appropriate. And I found that a biomedical lens at times has kept me alive, whilst to others it's imparted a lot more harm than it has good. So, what makes a digital tool effective, safe, and helpful? Community allows lived experience folk to connect with one another and brings them back to a platform. There is a bit of debate around concern, I guess, for tip sharing, and this does need to have safeguards in place. But at the same time, community is what empowers people to move forward towards their healing. We also mustn't lose sight of the fact that digital tools are a necessary and accessible alternative in a world that is so costly, in which there are such long wait lists and which services are often under-resourced. We need digital and online options. All of my positive experiences with digital tools have been customizable, which ties back to the idea that different approaches work for different people. We also need to hold in mind that as someone with an eating disorder, it's not just that you're experiencing an eating disorder. We need a tool that focuses not ultimately on just the eating and the food. I understand why, but the reality is that many tools that try to move away from disordered eating do so by focusing on eating, which we know fundamentally eating disorders are not just about the food. A relevant note here is that many folks have negative experiences with logging food through weight loss apps, so we're not coming into this space unbiased as well. It also lends itself well to the fact that many service providers perceive ads, perceive things that are being helpful that actually just don't translate in the way that they think it does. Another example of that is quotes and affirmations, which have always frustrated me. Things like eat it to beat it. To me, what I phrase as inspiration porn feels infantilizing, especially for neurodivergent folk who typically have a significant capacity for pattern recognition. It can feel really ingenuine and forced. My top 5 recommendations. So 5, be informed by intersectionality. Eating disorders do not exist in silos, and focusing just on eating and body concerns is not going to address the root concerns. 4, focus on building community. People feel that they belong when they are a part of supportive networks, and they're more likely to stick around and engage. 3, personalization is key. We need to give people options to tailor their experience on a platform, because what works for one will not work for everyone. 2, operate in shades of grey. Recovery is complex and often messy, and that is what makes it true. Tools need to avoid rigidity as much as possible and embrace a more nuanced approach that acknowledges individuals' experience. My main recommendation is that of co-design and co-evaluation led by those with lived experience. Co-design works for many reasons. It's quite literally asking directly what the intended audience needs and wants while simultaneously empowering them in the process. Solutions to the challenges that we're facing already exist, and when we ask the right people, they don't need to be invented. We just need to funnel them. True co-design empowers individuals and communities, making them integral parts of the process. This collaboration will lead to more effective and sustainable outcomes on projects. My role in Consumers of Mental Health Western Australia, through this, I've seen the success of co-design firsthand. Collaborate to Connect is a co-design set of training that helps organizations to co-design. So yes, it's a co-design training. I've been majorly impressed by the way that this is being developed so collaboratively and transparently. I began on the project as a part of their consumer advisory group, and then through a lot of hard work and advocacy, I actually started working at Consumers in Mental Health Western Australia on another project that was also co-designed. In the mental health lived experience field, the lines between consumer and professional can often blur. Having navigated both gives me a unique insight. So what was the difference in the way that I was treated and respected? Surprisingly, not much. The value that I always felt, and I guess I'd never felt diminished. However, my influence on the project had shifted more so. So as opposed to focusing on providing my reflections, I was more funneling those of the groups that we were working with. Coming back to the key messages of the day, what I hope you leave knowing, understanding, and holding is this. Eating disorders are messy and ambiguous, so tools need to accept and embrace this reality. There simply never will be a tool that works for everyone. Everyone's needs are so different. And lived experience is essential for us to progress in the mental health space. We need to make a conscious effort to platform these voices. Thank you for listening. If you want to reach out to me, please feel free to take a screenshot of this screen, and I am more than happy to chat.
Thank you very much, Rachel. Such a wonderful presentation, and thank you for sharing your personal experience as well. And one of the questions I get most often is around engaging people with lived voice and how to do that in a meaningful way. So that's something definitely I'd like to come back to as well later on in the session that we can chat more about. Thank you so much. Wonderful. So now I'll call on Dr. Jorge Palacios. And Jorge, would you like to join? Wonderful. So Jorge drives the research and scientific strategy for Bright Therapeutics, working on leading DTX products such as Recovery Record for eating disorders, Recovery Path for substance use disorders, and Mood Links for depression and anxiety disorders. And prior to Bright, Jorge completed his medical training in Mexico City and obtained his PhD from King's College London in psychological medicine. He then helped shape and lead research and implementation of digital interventions at Silver Cloud Health through to its acquisition by Amwell. A global advocate for digital therapeutics, his award-winning work has been featured in top academic journals, and he speaks widely on expanding access and improving engagement with evidence-based digital interventions. So Dr. Palacios will share some key insights from his work with Recovery Record and how engagement, evaluation, and data-driven best practice with digital interventions specifically applies to the field of eating disorders. We can't wait to hear from you, Jorge. Over to you.
Thanks, Maureen. Thank you so much for that lovely introduction and for the invite. Can I confirm that you can see my screen and hear me okay?
Yes, we can.
All right. So hello world. I really want to say, because I've seen already that there's people joining from Tasmania. That's super cool. Australia, Canada, and shout out to Alice, who's also joining from London and pulling an all-nighter alongside me. This is what we have to contend with when we do global webinars. But I think it's super cool that we're doing it. Anyway, I could talk more about this, but time is of the essence. And like Rachel, I want to give just a few insights or things that I've learned in my years of working with digital interventions and specifically for eating disorders. So I'm going to get right to it. And I basically have structured my short presentation around 5 key points or statements, right? So we're talking about digital here, and it's certainly not the finish line. It's just the starting point. Implementation of a digital intervention within a clinic or by a clinician with his or her patients is just the beginning. So yes, there's a lot of barriers to proper digital intervention, but most of them aren't technical. They're actually human and systemic. So there's a lot of clinician hesitation and low confidence with digital. Of course, that's to be expected. And there can be misalignment with the existing workflows that have, been there for years at a clinic. The training and onboarding can be lacking, and the clarity of who's managing what and what each person's new role is going to be with this digital solution in the mix is also sometimes not great. So in eating disorders, care is relational, it's nuanced, it's multidisciplinary. So tools must fit in within that existing rhythm and not disrupt it. That's key. It's not meant to come in and replace, it's meant to support clinicians. So that worry that digital tools can oversimplify or replace that human connection should be squashed from the beginning, ideally addressed upfront and build that trust. We have certainly abided by all of these principles, and as of April 2025, I'm happy to say that Recovery Record has now been used by over 2 million people around the world. In 2024 alone, we had over 19.7 million logs on the app, which is a crazy number, but it's incredible because we believe primarily in access, but also because it's such a global issue. And this is why this webinar is super important. You'll see in my slides some references of the research that I've published, that we've published at Recovery Record. Please reach out if you want to know more in the full text. But anyway, the next statement, which is really important, is if a digital solution doesn't feel useful, it just won't get used, right? So it sounds obvious, but it's absolutely true. Engagement is something that I've published a lot about. And for those of you who might be looking to attend the next ISET, I'm going to give a workshop on engagement on digital interventions there. And what I've learned, quite a few things, but some of the primary ones are that early engagement is super important. Like that early engagement, which is driven by relevance, drives retention, which ultimately drives outcomes. So these tools must help users meet a real need, and I'll talk about that more, but it has to be quick, right? By relevance, I also mean they have to strike the right tone, content, and frequency. So frequency meaning you need to understand how often patients and users should use and log into the tool for it to work. But importantly, engagement increases when tools reflect the user's language, their identity, their goals in the moment. You have to meet them where they are. And for eating disorders, tools must be safe and non-judgmental, of course. One example for us is patients on our app wanted to connect with other patients, and so we built in this pair up feature, but we made it pseudo anonymous only, so that they wouldn't be judged. The meal logs, we've gotten feedback that validate the experience without having patients feeling judged. So that's super important to us and should be for any digital solution. Research should shape the product and vice versa. What I mean by that is research and rapid insight analysis, A/B testing, large trials, they all help to answer important questions about the product, about what is working and what is not. It can reveal friction points before complaints arise and obviously dropouts. If someone doesn't like the app, they're just going to stop using it, right? For us, there's been a continuous feedback that has helped product development. We've done surveys, data insights, obviously our published papers, they've all fed into that. And we've also used engagement data to spot certain features that just haven't worked properly or backfired. So for example, we installed a DBT diary card on our product, but patients didn't like that disabled the thought logs and coping skills that they could do independently. So we put them back and personalized it so the patients could use it outside of the DBT diary card. Overall, we've made over 50 updates to recovery record throughout the years, and this again has been driven by data and rapid experimentation. So speaking of evidence, RCTs, randomized controlled trials, yes, they're the gold standard, but they're just a brick in the wall, pardon the Pink Floyd reference. It's not the whole wall. So yes, you need to build a wall of evidence, but that can come from RCTs, but also real world evaluation, mixed methods, observational data, all of that paints the whole picture. For example, we just published a paper looking at using advanced statistical methods and real world analysis, and we saw that users of recovery record had less disease-specific emergency room visits, but also that they attended more outpatient visits. So, this was real-world evidence. It wasn't an RCT, but it also mimicked an RCT because we compared recovery record users to those who weren't within the same healthcare system, right? So it's important to consider all of this when building evidence and when judging evidence of digital solutions. And finally, when considering digital tools and how they're implemented, it's not scale that should be chased, it's fit and adaptation. So scale without adaptation leads to drop-off and harm. And fit means cultural relevance, accessibility, and sensitivity. So small pivots about language, small visuals about inclusion make a big difference, right? We have a lot of partnerships with collaborators across the world. We've translated our app into Danish, into German. We're translating and adapting it into Spanish, which I'm super excited about, being from Mexico. We've built a family app, and we're working with researchers to adapt it to Black population who binge eat. We developed a diabetes-specific app. So there's a lot of things yet to be done. Given the global audience here, I know there's still a lot more we can do, and I'm super excited about that. So I'll stop there. Looking forward to the discussion, and thank you as always for listening. Please get in touch.
Thank you very much, Jorge. And from what I understand, your app has also taken in all the relevant standards, and you wanted to make sure it was really a safe and effective app. So another kudos
100%.
to you around that, and just making sure that not only people are engaging with your app, but the app itself is really safe for folks to
Oh,
engage
for sure.
with.
Yeah,
So very
above
well
all.
done.
Thank you.
Wonderful. Thank you, Jorge. So I do see there's a lot of folks from all over the world joining us today, and just really wanted to thank everyone for logging in, whether it's morning for you or the evening or midday. So thank you very much, and it's so great to be able to see people from different communities and backgrounds and jurisdictions. Feel free to also add any questions that you have into the chat, and we'll make sure to address those questions either throughout the presentations or at the end in the webinar. So feel free to engage directly with us and the participants, and we'll make sure to watch out for those questions. Great, so now I'd like to call Ariel Smith to the webinar. And Ariel is a first-year clinical psychology PhD student at Northwestern University in Chicago, Illinois, United States. So a big welcome to you, Ariel.
Hi, thank you so much. I'm excited to be here. Let me just share my screen. Can you hear me?
Wonderful. And yes, I can. Yeah.
Oh, okay.
Thanks, Ariel. And Ariel is a member of the Lab for Scalable Mental Health, directed by Dr. Jessica Schleider. And Ariel's research focuses on the development and implementation of brief, scalable digital supports for youth with eating and body image concerns. And she is passionate about increasing access to care among groups that have been historically overlooked in eating disorders research and treatment. And prior to beginning her PhD, Ariel received a Bachelor of Arts in Psychological and Brain Sciences from Washington University in St. Louis. And Ariel will now discuss her lab's approach to designing single session interventions using accessible, relatable language, and how single session interventions can align with the eating disorder care system ecosystem moving forward. So looking forward to hearing more from you, Ariel, and feel free to share your screen if you would like.
Awesome. Okay, hi. Thank you so much, Maureen, for the introduction. I'm Ariel, and I'm super excited to speak with all of you from all over the world. Just to give you a little bit of context about why we think digital interventions might be especially useful for young people, since that's the population that my lab focuses on. Um, a lot of people end up developing an eating disorder when they're a teenager, and we know from research that intervening early is really important. But unfortunately, only about a quarter of any person with an eating disorder receives treatment. So digital interventions are great because they can really expand access to care, especially those that are considered self-help interventions, interventions that someone can do completely by themselves, since they're not limited by how many providers are available. Self-help interventions also help reduce some barriers that teens report making it difficult to get care, since they can be available anytime or anywhere, and ideally, they can be made available without parental permission, and they can be used anonymously. And research shows us that digital self-help tools for eating disorders and body image work. So there's a lot of potential, but we have a long way to go towards actually reaching and engaging teens who are struggling. So I'm going to talk about two paths forward that my lab has taken in this direction. One of the paths forward is reducing the issue of dropout by maximizing the benefits that people can obtain within just one session. So, dropout from interventions that are intended to be used for days, weeks, or even months is really common. And this worries us because we are concerned that people are downloading apps and not actually getting the intended dose. So, this graph here shows real world data of the percent of people who opened up a mental health app after they downloaded it. And you can see that just a couple days after they downloaded it, the drop off is really, really steep. And we don't have this data specifically for eating disorder focused apps, in part because so few are publicly available, which I'll come back to. But the dropout that we're seeing in research trials is telling us a pretty similar story. So one solution to address this engagement problem is to address it on its head by developing single session interventions. These single session interventions are specific structured programs that are intentionally designed to involve just one encounter with a clinic, provider, or program. They're not meant to replace other forms of treatment, but rather they're designed to bridge otherwise unfillable gaps in our mental health systems. And they work by targeting modifiable short-term beliefs or behaviors that, when those short-term improvements happen, can spur upward spirals of long-term change. And our lab's research, among others, has shown that single session interventions can help for lots of teen mental health problems. And more research is coming out suggesting that they can be helpful for eating disorder symptoms too. And this leads me to the other solution that my lab has been thinking about, which is designing interventions that center the needs and desires of the users that the intervention is intended for. One way to do that is to use topics and language that is actually relevant to your users, even if that language diverges from the language that we're commonly using as academics in our ivory towers. And in the context of my lab's work, what a lot of this has meant is turning to social media and seeing how young people are actually communicating about body image online. So here are just a few online posts highlighting this theme of young people distinguishing between body positivity and body neutrality. The idea being that body positivity promotes an unconditional self-love of your appearance, but this movement has been co-opted and is now viewed as exclusionary due to a lot of like corporate interest and trying to sell products with body positivity even. Whereas body neutrality emphasizes appreciation for the body's functions, a flexible and non-judgmental view of your body, and a disconnecting of your self-worth from how you view your appearance. In academic literature, this distinction isn't really clear-cut. The body image frameworks that actually underlie body positivity and body neutrality probably overlap, but my point here is that we can harness the online enthusiasm for body neutrality to engage people in evidence-based interventions differently and hopefully better than we would if we were just focusing on how body image is described in the academic literature. So we did that, and we designed a single session intervention for teens with body image concerns called Project Body Neutrality. And I'll just share a little bit in the next few slides about what this 20-minute session actually looks like. It starts with some basic education about how bodies are meant to look different and how you can be healthy at any size. Then there's a lot of peer testimonials that are designed to validate teens' body image struggles and emphasize opportunities for growth using body neutrality. And then once teens have a sense of what body neutrality is, there are activities to help them apply it to their own lives, including making a list of things that their body does for them that they appreciate and helping a fictional peer of their choice embrace body neutrality. And this all culminates in an action plan that summarizes the user's responses so that they can take their learnings into their life moving forward. So it's about making some short-term changes in the single session intervention that can cascade into longer-term changes by taking this action plan with you. And we tested Project Body Neutrality in 2 different trials now. I'll broadly share that the results are really strong with high completion rates, people rating the Project Body Neutrality a 4.5 out of 5 stars. We've made improvements based on pilot feedback to make an even better rated version for the next steps. And when we measure how people are doing right before and right after the intervention, they report better changes in hopelessness, functionality appreciation, and body dissatisfaction than those who got randomized to a control group. And when we look at how people's symptoms are doing months later, we find that Project Body Neutrality is better than the control group at reducing eating disorder symptoms for people who were originally at high risk for an eating disorder or had subclinical symptoms, but we do need to do research with larger samples to confirm this. And my final take-home point is that Project Body Neutrality is one SSI of many. No one SSI fits all, so what do we do with them? I think of the eating disorder treatment system like a life raft with holes in it. It's broken and we probably should replace it, but until we have something better, we can use SSIs to patch these holes and weather the storm. So here on the slides are just some examples of a couple of directions that SSIs can be used to patch these holes. My lab is working on a few of these right now, and I'm so encouraged by the work that others are doing as well. Thank you so much for listening, and my email is at the bottom of the slides if anyone wants to get in touch. And thank you so much to my team of amazing partners.
Thank you, Ariel. It was so wonderful to hear a bit about single session interventions and your experience and the success that you've had with them. We actually, the Mental Health Commission of Canada actually did a project regarding Step Care 2.0. So an approach to a stepped approach to mental health services in different provinces and territories in Canada. And part of that was actually using a single service intervention as well. So like a single session whenever people went in to seek treatment. And we had a lot of success with that approach as well. So it's really nice to be able to see it utilized in this way as well through an online platform and through an app. So thank you very much for that. Wonderful. So now I'll call Gemma to the conversation. Welcome, Gemma. And I'd like to introduce Professor Gemma Sharp, who is founding director of the Consortium for Research in Eating Disorders in Australia. And it's really wonderful to have you here, Gemma. Since launch in September 2024, hundreds of researchers, clinicians, people with lived experience, industry, and not-for-profit advocates have joined the Consortium for Research in Eating Disorders from over 20 countries. Gemma is also a professor and leads a body image and eating disorder research program and is a registered clinical psychologist and credentialed eating disorder clinician. She has led several world-first eating disorder-focused digital health initiatives, and Professor Sharp will wrap up the presentation today also by discussing CORE-ED's collaborative co-design approach and evaluation priorities, as well as the future opportunities, particularly through global online connections with Core ED and their mission. So looking forward to hearing more about that, and looking forward to connecting more with you after the webinar as well, personally, Gemma. So Gemma, I'll hand the floor over to you. And you're on mute. Yeah.
Thank you so much, Maureen. And just checking you can see my slide okay?
I can see it perfectly. Thank you.
Wonderful. Thank you so much, everyone, for joining us from around the world, and what amazing speakers we've had so far. I'm going to try my best to live up to their standards. And also, I know everyone is very keen to get to the discussion, so I'll try and keep this brief, but it is a huge honour to be the founding director of the Consortium for Research in Eating Disorders. As we often do in Australia, I just wanted to acknowledge the traditional owners of the lands in which we all find ourselves today. We're very proud of our partnership at Core ED with EMIC, and as Maureen said, there will be a recording available of this wonderful session, and we'll be disseminating it through our Core ED channels as well. Just very quickly about Core ED, and then I'll jump into more digital health work. As Maureen said, we're a first of its kind international initiative or charity, and we aim to bring together all voices involved in eating disorders research. So researchers, clinicians, people with a lived experience, advocates, not-for-profits, and industry representatives globally. And our overall goal is to promote innovations in eating disorders research by empowering all voices and ultimately creating new therapies for all people, especially digital therapies. We initiated Core ED in November 2023 and officially launched in September 2024. And in the 8 months since official launch, we're approaching 1,000 participants, which is super exciting, from over 20 countries, representing 5 continents and 17 international partners. And I can see quite a lot of our international partners online with us today. So thank you so much for joining. And we have indeed had those researchers, health professionals, advocates, lived experience and industry representatives join us. If you'd like to join us, just scan the QR code on the slide and you can join us for free. And when people have joined us, they've said that they want to connect, collaborate, and learn. And I think we've achieved all 3 of those already in this session, and we'll do more of that too. And the core tenet of Core ED is that all voices co-design that Rachel eloquently talked about at the start of this session. So as you can imagine, with 20 countries and 5 continents, having digital platforms for Core ED is extremely important. So we've got our website in the top left, our Core ED portal where we post our notices, discussion forums, one-to-one connections. We also have social media, and bottom right, our YouTube platform where we post recordings just like the one we're creating today. So I wanted to talk about one example that I was very fortunate to lead, and it was with our wonderful partners, the National Eating Disorder Information Centre in Canada, also known as NEDIC, and talk about how, I suppose, these international digital health initiatives can work. So back in casting your mind back to the COVID-19 pandemic, we realised that there was a huge need for early intervention and prevention for eating disorders. And that's how GEM Chatbot came about, and a chatbot being a conversational AI agent that tries to simulate human-like conversations. So on the left-hand side of the screen, that's GEM in Australia in its early form, and we're very lucky to have good success with GEM, connecting with now literally hundreds of thousands of people around the world. And we heard from our good friends in Canada, NEDIC in particular, and they said, hey, do you think GEM could work in Canada? And we were like, don't know, shall we try it out? I mean, long story short, GEM is now launched in Canada and has been very well used and received. But I wanted to highlight some important points and re-emphasize some points that our wonderful speakers have already talked about. So clearly our colleagues in Canada reaching out to us, they realized there was that need for early support and education, particularly in eating disorders. we went through an extensive co-design process in Australia to first off design GEM, but we realized that there was no way that that was going to directly translate in Canada, as Jorge eloquently put out, that there's cultural adaptations that are much needed. And so before GEM was in any way near launch in Canada, there was extensive work done by NEDIC and ourselves. Something else that's popped up, and I think Ariel talked about it really beautifully, is that extensive and comprehensive research evaluation. And so GEM has multiple types of surveys. We've done exit interviews. We look at the analytics. We look at the user journey. We try to bring together all this data to try and best understand how users are benefiting from GEM and also how to improve GEM in the future. And I think something that's been really, really cool about having a deployment of GEM chatbot in Australia and Canada is that knowledge exchange and the improvements on both sides. And I honestly think the version of GEM in Canada looks spectacular. And we've benefited a lot in Australia from the wonderful advice we've received from NEDIC. And I should say GEM is part of now a siblings of chatbots, and we have a chatbot called EDSE who delivers a single session intervention, as Ariel was talking about. So we're sort of using this AI technology at lots of different points in the eating disorder care spectrum. And just moving forward, I suppose our thoughts at Core ED on the use of, I suppose, particularly AI and digital health is that we're using AI for our routine administrative tasks already at Core ED, which is great. But as we've seen today and through my presentation, AI can be used as a therapeutic assistant, can also be used to train clinicians. And I think what most excites us about Core ED, digital health, and potential use of AI is big data collection across the globe that will allow us to synthesize people's eating disorder symptomology data and better predict who will benefit from what types of care. So that's something that we really look forward to at Core ED in the future with all of you. And we've been talking a lot about research, and you can imagine that this webinar is not an exception from our research platform. So if you'd like to tell us what you've thought of today's webinar, you're very welcome to scan the QR code. I'll also put a link in the chat because we want to improve, just like EMIC, and giving you the best educational opportunities we can. And I think it's been a really awesome session, and I really look forward to the discussion coming up. So I'm going to thank you all so much for listening and hand back to Maureen. Thanks, everyone.
Thank you very much for that, Gemma. And I'll also invite all the speakers now back to the room. And Gemma, it's so wonderful to see all the success that you've also had in Canada. So it's so great to be able to make these connections, and it's nice to be able to see in the chat. Everyone seems to know each other as well in this community, which is the case with EMIC events as well. And really looking forward to further discussions as well around the work that you're doing.
Thank you so much,
Wonderful.
Maureen.
Great. So I see that we have everyone back now. Thanks so much, everyone. So we're going to have a bit of a panel discussion now to talk a little to further some of the points that you discussed in your presentations. And just a reminder to our audience, please feel free to post your questions in the chat or the Q&A, and I'll also bring them into the discussion later. So let's start off with the topic of co-designing digital health tools. Rachel, you talked a bit about co-designing with people with a lived eating disorder experience, as well as other key stakeholders. And we know that this is crucial. But one of the items that I hear quite a bit about is tokenism. And we know it's a big issue when it comes to including lived experience in designing and also implementing digital solutions. So Rachel, we're wondering if you could talk to us a bit about what is real co-design and how is it best done?
I think this is something that I've really learned through my work with Consumers of Mental Health Western Australia, something that they do incredibly well. I've definitely learned that co-design is an ongoing process, that it doesn't stop once the project is developed. It's a part of a broader co-production process, which that in itself includes co-evaluation and just continuing to build this relationship and deliver the product with the people that you've been working with in the design as well. A tool that I find really useful is the Armstein's Ladder of Participation, which talks about the different levels of consumer community engagement. And I think that's really important to understand the difference between the non-participation levels that are more tokenistic and then the true participation more up the top, and understand that there's different situations for different levels of participation.
Yeah, that's right, Rachel. Thank you so much. And I think sometimes folks think they're doing co-design where they might actually be doing something different, like a consultation. So I think that is so wonderful to be able to share that and some resources. And my team also at the commission works with our lived experience councils, as I mentioned, and we developed with the councils a resource as well around how to meaningfully engage with people with lived experience. And it also discusses a spectrum, like you mentioned, Rachel. So I'm actually, I can put that link into the chat as well for everyone. I'm happy to do that. And this is hot off the press as well from March. So it aligns really nicely with your thoughts as well, Rachel. Great. So let's chat now a little bit about reaching and engaging with people who will benefit from eating disorder digital health tools, since we know it remains a big challenge around kind of the engaging part and also the access part. And the default is still a traditional black and white view of eating disorder support, but real progress means moving forward and meeting people where they're at. And some might not have access to the support, and others might also struggle with to engage with tools already out there. So that's why we really see access and engagement as two very different challenges. So I'll start first with access, and I'm hoping Ariel, you could also weigh in on this. But what are the main barriers you see to accessing care for eating disorders that digital mental health solutions can help address? And also, how should we approach the digital divide?
Thank you so much for this really good question, Maureen. And I'll answer it within the context of my lab's work, which is focused on adolescents, because I do think we also need to think about how barriers might be different for different populations. So in the context of young people, parent-related barriers are perhaps the biggest barrier to getting care, which is difficult because some of our frontline treatments for eating disorders for young people do involve families. But if we are thinking creatively about alternatives and we want to get someone something that doesn't have anything, we really need to make these tools available to folks without parental consent, which requires sometimes even working with government and informing public policy so that teens are able to actually access these tools on their own. And often they're more comfortable doing so, and this can be totally anonymous. And to your other question about addressing things like the digital divide, it's one thing to have interventions like kind of available, like in the big big World Wide Web. It's another thing to actually have those digital tools embedded within infrastructures where people can actually use them. So some of the things that my lab is doing now is thinking about how to bring digital single session interventions into schools, into libraries, into primary care, like on tablets or computers, so that they are more available during moments of need and not reliant on people's individual technology capabilities and access.
Yeah, that's wonderful, Ariel. It's something that we're also seeing kind of in the larger mental health app space as well, is, trying to be that liaison between access. So, folks that are really needing the resource can access it, and it might be through schools, it might be through kind of other channels that people are, finding apps or other resources. So thank you so much for being that liaison between youth and the platform, the great platform that you developed. So thank you very much. Great. And so for the next question, I'll open it up to everyone and hoping we can have a little bit of a discussion on this and share some of your experience. But there's a growing movement in Canada, and I know that Shailene Jones is on the call, and she might also be able to speak to this. But the movement is around using digital solutions to address stigma. And anonymity seems to be especially important in the context of eating disorders. And it's been said that this population often feels more comfortable engaging with an online service since they often feel less judged rather than walking into an in-person service. So, wondering if you can tell me a bit about what are your experiences with stigma and digital tool adoption in the countries or the communities that you work with?
I can start with a general view because this I think is applied with all of our users. In fact, one of the reasons why Recovery Record was even thought up was to address the stigma that patients would have about taking pen and paper and writing down their meals and their thoughts in a public setting or even in a private setting with other family members or friends present. So, you know, the one of the initial hooks of the and still remains a hook of the app is to be able to take a picture of your meal and then have the app ask you the questions. Well, not only guess what that meal is, so you're taking a picture of an apple, it'll tell you apple, so you just click yes, it's an apple, and then it starts to ask questions about how you feel in that moment and addressing the skills, the behaviors, the thoughts that you've already logged in the app. Point is that it removes that stigma of like having your eating disorder out there for everyone to see or judge, at least in their perception. So that was one of the initial things that this digital tool addressed, but that's, you know, more general. Obviously, each culture has its own intricacies about stigma and weight and body image, but yeah, that was just a general one that I think our digital solution at least provides.
A really great point, one I hadn't thought of before as well. Thank you so much for sharing that. Would anyone else like to weigh in?
I'd love to speak to my perspective. Or Gemma, did you want to say something?
You go for it, Rachel.
Awesome. I think as a person with lived experience of an eating disorder, it's very much a case of a lot of the treatment that we experience can be very punitive. So actually going in to receive treatment, going in person, you're opening yourself up to, I guess, potentially feeling that you're being punished or that you're being threatened in that treatment. As opposed to a digital tool is more safe. You can do it on your terms. You've got your own autonomy. I think it's really just important to recognize that there is still that reality that treatment doesn't feel safe most of the time.
That's a great point as well. Thank you so much for sharing that, Rachel. Gemma, did you want to jump in as well?
I will, and I know there's many more questions to get to, Maureen, so I'll keep it brief. I suppose we've seen in particular because Gem was freely accessible on a website. It was completely anonymous and really, I suppose, early treatment seeking. We saw a very high proportion of people who identify as LGBTIQA+, as well as culturally and linguistically diverse who wouldn't normally call the associated helpline or go for that in-person support. And we did see in their responses that they really liked that anonymity and knowing that the chatbot had been trained not to stigmatize, obviously, was reassuring for them. So we've definitely seen it in action, that it opens up another pathway for people to feel more comfortable.
Yeah, that's really wonderful. Thank you so much for sharing that, Gemma, and your experience. Great. And I'm also seeing a question in the chat around where are all these astonishing apps located. So if anyone would like to also put a link to their app in the chat, that would be wonderful, or their platform. And we'll also get to any of the other questions a little bit later on. So let's jump on then to the next topic. There are more considerations to be taken into account in eating disorder digital tool development, particularly neurodivergent status of the user. So we know that no one tool will really suit all. And this is something that many of you have addressed in your presentation as well. So wondering if you could tell us if you have any thoughts on the need to consider cultural intricacies and certain demographics, such as age, for example, some folks mentioned youth, when it comes to designing tools for eating disorders. So Rachel, I don't know if you wanted to get started on that question, or anyone else on the call.
Yeah, sure. I mean, I think that a lot of the treatments that we have are very there's not a whole lot of support for people who are neurodivergent, despite the links that we know exist between neurodivergence and eating disorders. As someone who's I think neurodivergent people have a very strong ability to recognize patterns. And as soon as you start going along that pattern of something that you've been taught or something that you've learned, it can feel very ingenuine. I know that as soon as a clinician starts saying something to me, or I start seeing something that feels like it's been rehearsed or that it's been read out of a textbook, I can identify it immediately. So I think that's a factor to consider as well, is that we don't want to do this tokenistically.
Thanks so much,
Um,
Rachel. That is so important. Yep, go ahead, Jorge.
Yeah, well, sorry, I just wanted to add how important I think this subject is, and just to give an example, when now that we're adapting it into Spanish, beside the translation and cultural adaptation of the language, the subject of food is just like so different from place to place. We talk about it all the time outside of the context of eating disorders, not just obviously the types of food, but how food is conceived, at what points of the day, with who do you eat? Like, is it part of a, in Mexico, it's a big meal, and like you stay at the table for about an hour after the meal. We have a word for that that's not even in English. So there's a lot of things around eating and around just the body image, the body type that women aspire to in Latin America versus European countries or Western first world countries. So there are so many important things to consider, so that when someone is using this digital tool, it actually speaks to them, right? And so that's why it's super important, and that's why in this translation we're working with a clinic in Mexico, and then we're going to adapt it for the US Latin population and beyond, and make smaller and smaller adaptations as we go into each different country. But yeah, it's ideally you want how many countries are there in the United Nations? 250. Ideally, you would have 250 different versions, because
Yeah.
none is the same. But yeah, we'll hopefully get there.
Yeah, it's such a great point. And I think the pages of magazines in different countries also would
Yeah.
look very different in terms of, kind of like you described, what is influencing people, in terms of the ideal body image for certain countries. So it's a really wonderful point. I'm mindful of time. I did want to take a question from the chat, and then we might move to our wrap-up question as well. And if you have any other questions, please do enter it into the chat or Q&A. But how about eating disorder prevention? Is there similar efficacy using the digital modality? That's a great question. I don't know, there was some talk around schools. Ariel, I don't know if you wanted to discuss that around prevention, or if anyone else wanted to weigh in.
I can talk about prevention as I understand it. So, everyone feel free to chime in. I think that we really need more what are called indicated interventions. So, finding people when they're at high risk, right before they develop like a full eating disorder, because we don't really have any of those programs actually available, like in the US, like in the real world right now. Whereas we do have more universal prevention programs available, where there's like discussion groups in schools about body image. So with talking about prevention, it's also important to know that there's different kinds of prevention. And we are needing to do more research to explore all of these different options.
That's a really great point. Yeah, thank you, Ariel. So let's move then to the final wrap-up question. I can't believe we're at time, but perhaps maybe just in like 20 seconds, if we'll go around the table to answer this question. But could you tell me what excites you most about where digital health care is and heading towards eating disorder care? So what excites you most about where digital health is heading in eating disorder care? So maybe I'll start, if it's okay. I'll start with Rachel, and then I'll go to Jorge, Gemma, and Ariel.
Amazing. What excites me most is seeing lived experience come on board. I have talked about it for pretty much the whole time today, but lived experience really is the way that we move forward. again, I think it's the people using these services have so much to give, have so much, they know what they need. It's a case of listening to them and allowing them to have that platform.
Thanks so much, Rachel. Great. Jorge.
Lots of things, but in 20 seconds, I just want to say more and more people are talking about it. For us, it's about access, and adaptations is the way to go. And I know that we're going to make a lot of inroads in that. The more and more people talk about it across the world, we're going to adapt and embrace digital solutions as a part of getting more people the care they deserve. So I'm really excited to see that.
Thanks, Jorge. Over to Gemma.
Thanks so much, Maureen. Second everything Rachel and Jorge have said, and I'm sure I'll second what Ariel's about to say. I think it's just that global perspective, and particularly with Corey D, learning from each other and that all voices approach. That's what really excites me about digital health.
Wonderful.
And I'll just
A great
finish off with saying work to reduce the research to practice gap and designing hybrid effectiveness trials where we're actually looking at do our digital interventions work, and how do we implement them in the real world at the same time.
Which is a challenge. Thank you. That's a really great way to end off, and a great call to action, I think, for all the folks on the call today. So I wanted to say a huge thank you to each of our panelists, Rachel, Jorge, Ariel, and Gemma, and a big thank you to Olivia and Anil with EMIC as well for hosting this webinar. Thank you so much to you all as participants for your participation and your engagement, and have a wonderful day or evening ahead wherever you are in the world. Thanks, everyone.
Thank you.